Namaskar, a very good evening to all of you, and a very good morning to the speaker, sir. On behalf of ISVM, I welcome all of you on this 21st consecutive webinar of ISVM, Indian Society for Veterinary Medicine. And I'm happy to announce that we have not yet taken a break even once. So I welcome Dr. Amandeep Chohan. Before starting his webinar, I will just introduce about his brief biodata. Dr. Amandeep did his BVSC and MVSC from PAU Ludhiana, and then did MS in veterinary anesthesiology from Washington State University, US, during 2006 to 2009. Then he became clinical instructor in anesthesiology at Washington State University from 2009 to 2015. And now he is currently a clinical assistant professor of anesthesia and analgesia at University of California, Davis. And his research interests are minimally invasive cardiovascular monitoring and impact of various anesthetic drugs on central nervous system. So I welcome on behalf of ISVM, I welcome you, sir, and I also welcome all, especially the organizers from DUVASU. Earlier it was called PAU. I also welcome, and now all come on to Dr. Amandeep, sir.
Okay.
Only make it full screen, sir.
Okay. Is it full screen now, Dr. Nilesh?
No, sir, it's not full screen. The outline mode, kindly go on the swap display mode on the upper side. Make it duplicate one. Swap display mode.
Oh, still the same.
Third point, sir. Kindly make it full screen. Kindly open the presentation, sir. Yes, sir. Now make it full screen from down, sir.
There you go.
Yes, sir. Perfect. Sir.
Awesome.
Perfect.
Well, thank you so much, everybody, especially the organizers from ISVM and my mentors from DUVASU who offered me this opportunity to come in front of you guys and talk about a topic which is at the core of critical care medicine and a lot of the stuff that I, as an anesthesiologist, delve into every day. And we are all in medicine, and one of the most devastating things that can happen to any of us is to lose a patient. So be able to deal with that scenario effectively and hopefully come up with a better outcome when you are trying to resuscitate such patients, I think is a huge joy for any of us. And that's exactly why we are going to talk about the cardiopulmonary resuscitation today in veterinary medicine. And I was mostly focused on small animal medicine, so in dogs and cats. There is not tons of data in large animal medicine, so we'll mostly focus on guidelines and recommendations that we have for small animal patients. So the way I've organized this talk is we'll briefly talk about cardiopulmonary arrest in small animals and why it is very important to make sure we follow the latest evidence-based guidelines. And then finally, the bulk of time we will present or talk about what are the different components of that CPR protocol or the guidelines, and we'll focus on basic life support, advanced life support, what sort of monitoring we should do during CPR, and not just during CPR, but once you've got a patient back, now how do we keep them alive? So that's another very important part that we miss sometimes. So the post-cardiac arrest care. So once you've got them back, how to care for those patients. So cardiopulmonary arrest is essentially cessation or stoppage of ventilation and systemic perfusion. It is associated with a huge mortality rate. And if you look at the data in small animal medicine, the rate of return of spontaneous circulation, that is how many times we actually get those patient backs, is about 40 to 50%. So pretty decent, but that does not matter. Because the actual thing that matters is that how many of those patients get out of the hospital alive. So if you look at that data in dogs, the survival to discharge rate is only about 6%. And in case of cats, it's about 3 to 6%. So obviously, a very small percentage of these animals actually make it alive out of the hospital. So proficiency or your ability to conduct CPR in these animals, it's a highly, highly valued skill anywhere. And this is especially important in the field of, for people like me who are working in perioperative medicine and in emergency and critical care medicine. So knowing that we already have a very low rate of a hospital discharge in these animals, it is very important that we do anything and everything to improve their outcome. So the one way to do that is to make sure the practice of CPR is up to date. The guidelines that are there, we are adhering to those guidelines. And that's exactly what we're going to talk about today. So knowing that there's a huge gap in the evidence in the veterinary medicine, because traditionally we have done CPR in many different ways. There had been no consensus that, this is how you should do chest compressions, this is how you should give drugs, these are the drugs that you should give. So there was no consensus. So what recently was done in the veterinary medicine is that they came out with this campaign. In short form, this campaign is called the Recover Campaign, which stands for the Reassessment Campaign on Veterinary Resuscitation. And what these folks did essentially, they got together from the field of veterinary anesthesiology and critical care medicine, and they looked at all the data available in veterinary literature to see what is the evidence to prove or disapprove what we do or how we do things. And then they also collaborated with human folks, people from International Liaison Committee on Resuscitation from human side, to come up with some standard guidelines that, okay, this is the way we should do these CPR when we are faced with such scenarios. And they looked at 5 key areas. So first area was the preparedness and prevention. How can we prepare ourselves to deal with this crisis? And then the basic life support, then the advanced life support, then the monitoring during CPR, and then finally the post-cardiac arrest care, that once you get them back, how to care for these animals. So this is exactly what we will focus on today in our talk, these 5 key areas that, what is the evidence, what are the suggestions, what are the guidelines that's been suggested in these 5 major areas of CPR. Now, we talk about evidence-based practice, that we should adhere to the evidence, what is out there, and stick with that. And this study from Japan, it essentially looked at the outcome in animals that arrested. So they used a conventional or a traditional group where they did a CPR like they were always doing. And then they had a recover group where they essentially used the newer guidelines that are being suggested by the recover group. And I just want to point out from this data, if you look at the achievement of return of spontaneous circulation, in the traditional group, they got only 17% animals back. In the recover group, they got about 43%, so a huge difference. If we further look at the survival to discharge, how many of those patients actually made it out of the hospital? So none of the animals in traditional group, but about 5% animals still from the recover group were able to be discharged successfully after doing CPR when you followed the recover guidelines. So the data kind of suggests that if you are following these newer precise guidelines, chances are that you would have a better outcome. So let's start with the first key area, the preparedness, that, what are the key things in that preparation that we should be ready with when we are faced with these type of scenarios. So proficiency in CPR skill and knowledge. So the first step is didactic training, going through lectures, online courses. So hopefully this is part of that, the didactic training that you guys are having today. For the hands-on practice, so once you have that lecture series, then the next step is that you have a chance to explore those in reality. So you could do a simulation scenario, or even if you are faced with an actual scenario, you always do a debrief. If you have a patient that arrested and whatever happened with that patient, you get together with your team at the end and talk about, okay, what happened? What was that we did right? What was that we did wrong? So that is what the debrief is. Actually gives you an opportunity to make sure you can reflect upon what went well, and that's how you would guide your future practice. And then the refresher training, that it doesn't matter, if you've done it, early in the year, if you don't follow up, if you don't keep track of, those things, if you don't revise, you lose that. So what the guidelines suggest that you should have a refresher training every about 6 months. You should have a crash available in a central location. Let's say if you have a lot of your patient in a key area in ICU or in the operating rooms, you should have a place, an area where you store all your supplies that you would need if your patient arrests, because you don't want to run around to find those things when a patient is arrested, because time is key in those situations. Sooner you can intervene, better the outcome. So make sure you have a crash cart like it's shown here in the picture. It is one of our crash carts in the hospital that we use, which is stocked with all the drugs and supplies that we will need if we are indeed conducting CPR. Cognitive aids, which involves that you should have different type of algorithms made up, and they should be pasted on the walls, so that in that case, if you have those algorithms available, you can have them available on the walls. You don't have to remember anything. If you're in that scenario, you simply look at that algorithm. For example, on the slide, I'm showing you a CPR algorithm, which is different steps that you should follow if you are doing a CPR. So if you don't remember something, you can simply look at that and know, oh, exactly, this is what I need to do right now. Okay, Dr. If you're hearing, it looks like I'm in the annotation mode and I can't move my slide forward.
I'm trying, sir.
Okay. Sorry about that, folks.
No issue, sir. You have to close the presentation, then start again, sir.
Whoa, okay. Let's see. So Dr. Nilesh, it seems I can't even find my mouse pointer on my screen.
Kindly press Command plus Tab. You will go to another window, sir.
Okay. Okay.
Then you can close, sir.
Okay, let's see. Actually, at least I can find my mouse pointer now. Let's see if I could. So I do need to get out. Okay. Okay.
You can also make it bigger one. No full screen required, sir. You can make it bigger one.
Okay. Okay, there you are. Okay. All right, we're back. Sorry for that, guys. All right. So the CPR algorithm should be available that you can use to paste on the walls where you're doing CPR. In addition, you should have some charts, some dosing chart for different drugs that you're going to use during that CPR. So this is just one chart that's been suggested by the recover here in United States. As you can see, it has different drugs with their doses available, because if you are trying to give drugs to a patient that is in arrest, you do not have time to grab your calculator and make calculations. You should have a way to simply look at something and know, okay, if this patient is these many kilograms or pounds, how much drug I should do, or how much drug I should give to this animal. So you should quickly access that information. People should be trained that how to properly use these algorithms if you are indeed in such crisis situation. So this picture simply shows that these different algorithms have been designed to put on walls in different areas where CPR is conducted. Picture on the right side here shows the picture from our emergency room, where we have a crash card available, and then we have a drug sheet available right on top of that, so that we exactly know what to give if we are doing indeed a CPR. Other important thing, obviously, obvious question is that, how do we know if a patient is actually arrested? So anytime you have a patient that is acutely unresponsive, look at their level of consciousness. Are they breathing or not? In addition, when they are under general anesthesia, using things like end-tidal carbon dioxide concentration, their arterial blood pressure, and electrocardiography, that can also yield an important information about the status of your cardiorespiratory system. If you do indeed feel that the patient is arresting or is arrested, you should do a very brief physical exam. That means only 10 to 15 seconds, not a clinical medicine physical exam where you spend a lot of time to do a physical examination. So when you have only 10, 15 minutes, your focus should be airway, breathing, and circulation. You quickly look at those three key areas. That what is the problem? Where is the problem? Is the airway obstructed? Is the animal able to breathe or not? Is there a pulse? Now, with the pulse, I want to make a comment here is that what the guidelines suggest that there is a high rate of false positive when you're getting the pulses. So you should not simply rely on the pulses for assessing the circulation. Look at multiple things to give you that information. Then the further step comes is that, once you know your patient is indeed arrested, that you start the CPR. So it is very important that you minimize the time between when you have called the patient is arrested and then you start the CPR, because that is the key factor that is going to determine if your patient actually makes it through that crisis. If you have any doubt that the patient is arrested or not, it is always a good idea to start a CPR, even if you have not a firm understanding or idea that, is the heart beating or is the patient having any ventilation or not. You should start a CPR, because longer you wait for other diagnostics to tell you that the patient is actually arrested, you're losing time. So it's very important that even if you have any slight indication that this might be a scenario, start the CPR, because the data suggests that if you do a CPR on an animal that is not actually arrested, you're not going to cause any significant harm by doing that. But if they had actually arrested and you didn't do anything, then there are chances that you could have a poor outcome because you delayed things quite a bit. Okay, so let's move on to our second area of our CPR guidelines, which is our basic life support, a very important area of CPR care in our patients. So the objective of basic life support is essentially to restore, to reestablish, to establish the oxygenation, ventilation, and perfusion to all our vital organs. Obviously, heart and the brain are the key organs which we want to make sure that we reperfuse them, we oxygenate them in timely fashion. And basic life support encompasses two main key areas. So one is the chest compressions, and the second is the positive pressure ventilation. So two key areas of basic life support. And it's been shown time and time again that a high quality basic life support, which involves minimal delays and pauses, is associated with a much better survival to discharge. So if you can start your compressions and you're doing your compressions in a good fashion, chances are you can definitely improve outcome in those animals. So let's start with the chest compressions. So during cardiopulmonary arrest, because there is no blood flow, so what it leads to essentially is depletion of your energy stores in different organ systems, in the different cells. So this leads to ischemic organ injury. And once you reestablish the flow, when the return of spontaneous circulation happens, it causes reperfusion injury. So what we can do is that we can timely initiate our basic life support, our compressions, so that we can minimize any of these potential harms to our patient. Now, the experimental data from pigs and probably some dogs as well, which suggests that when you are doing chest compressions, even if you're doing a very effective chest compression, you can only generate about 25 to 40% of your normal cardiac output. So you can imagine that if you're doing a great job, that is the only cardiac output you're getting, 25 to 40%. So it is very important that you adhere to the guidelines in terms of proper technique, the posture when you're doing compressions, and where you should actually compress, the compression point on the chest. So they're all important points to think about when you're doing chest compressions in these animals. So let's start with the technique. So they suggest that most of these animals that you're doing CPR on, the lateral recumbency, and the rate of your chest compressions should be about 100 to 120 compressions per minute. Other important thing is that, how far you should compress the chest. And the guidelines suggest that you should compress at least 1/3 to 1/2 of the chest's width, from lateral to lateral side. So about 1/3 to 1/2 of the depth of your chest. And then further, you should allow the chest to recoil fully. If you don't allow the chest to recoil fully, you maintain that positive pressure in the chest. And that is not the greatest thing. You need that for perfusion, but a very high or sustained positive pressure in the chest can impact your preload. If the preload is impacted, your cardiac output could go down. So very important that you allow that chest to move back up to the full extent. And then one of the most important guideline in compressions is that you should do uninterrupted cycle of 2 minutes contractions. You should not stop completed those 2 seconds, 2 minute period. And at the end of those 2 minutes, you can give about 3 to 5 seconds, not minutes, to quickly evaluate your patient. Okay, is it doing anything good or not? And once you have done a cycle of 2 minutes, if you have multiple people available, you should probably change the person who is doing the compressions. Because if you look at the data from human side and some experimental data, they suggest that we don't realize, we feel that, okay, we have done 2 minutes, but we can still keep going. But those people actually do get tired. So if you're tired, you cannot do effective compression. So if you have multiple people available, make sure you are rotating between different people to make sure that the strength of that compression is maintained. Again, uninterrupted cycle of 2 minutes, because if you look at the experimental data again from pigs, it suggests that you need at least 60 seconds of continuous chest compressions to establish maximum coronary perfusion. So that's the key here, right? To be able to perfuse your myocardium and your brain. So you need at least 60 seconds of continuous effective compressions before you can establish that. Since we are saying that they need to be uninterrupted 2 minute cycles, if you're trying to put a catheter in, if you're trying to do endotracheal intubation, all that should happen while somebody is doing the compressions. They should not stop the compression during all that time. And when you have done your 2 minute cycle, then in 3 to 5 seconds after that, you're evaluating the rhythm. You look at your electrocardiogram. Okay, what sort of rhythm does the patient have? And then from that rhythm, as we'll talk further, what sort of treatment is desirable based on that rhythm in that patient. So let's talk about the posture, since we know that compressions are a key area of this recommendation or this basic life support, that how can we do best compression? So if you just look at the picture here, the way the lady is standing on top of the dog is that she has her elbows, they're locked. There is no flex in the elbow. Her hands, they are interlocked, and there is only one focal compression point, the way she has interlocked her hands. Then her shoulders, they are right on top of her hands. There is no angle between the hands and where the shoulders are. So if you are a short person, you might need a stool or a table to stand on top of it so that you can get to that right posture. and then further use your core body muscles, your rectus, your six-pack. Time to make your six-pack here, guys. So use your core body muscles. Don't use your biceps or your triceps. Use your core muscles to deliver that. And finally, avoid leaning, because if you lean on the dog, when you get tired, you tend to lean on your subjects, on your dogs. And when that happens, that will prevent the chest from recoiling it all the way up. And we talked about that why that recoiling is important, because when there is negative pressure in the chest, that's when it sucks more blood into the chest as well. So a proper full recoil is also very important in these animals. This again is a picture of showing that how to have a proper posture when you are doing compressions. Again, elbows are locked, shoulders right on top of your hands, hands interlocked, and using your core muscles to deliver that compression. Then the further point is compression point. So we deal with different breeds of dogs, and they all have variable type of chest conformation. So depending on their chest conformation, the compression point is different. So if you are working with a round-chested dog like a Labrador Retriever, the guidelines recommend that your hands should be on the widest part of the chest. If you are working with keel or deep-chested dogs like Sighthounds or Dobermans, then your hands should be directly placed on top of the heart. If you are working with flat-chested dogs like brachycephalic breeds, you have English dogs, for example. Now, these dogs should be put in dorsal recumbency. Most other situations, the animals are in lateral, but in this case, they should be in dorsal recumbency, and your hands should be on the mid-sternum part of their body. If you are with cats or small dogs, in that case, you could use either one-hand technique as shown in picture A, where you just put your hand around the sternum and your thumb is on one side and your four fingers are on another side. So in that case, you just use your hand to squeeze the chest around the heart. Or you could also do a two-hand technique where your hands should be directly on top of the heart. Okay, so Dr. Nilesh, looks like I'll have to forego this option of annotation, because anytime we try to do that, the slide do not move forward.
Yes, sir.
So
yes, sir.
Yeah, so I'll see if I can get into that.
Command
I'm sorry about that trouble.
Command plus tab.
Let's see. Okay. All right. Okay. All right. So compressions is the first step in basic life support. Then you move on to the second important part, which is your ventilation. So while somebody to think about, okay, do I need to ventilate? Can I ventilate this patient? How do I ventilate that patient? So there could be two scenarios. So you have the first scenario where you are actually able to ventilate your animal. So in this case, you at least need two people, right? You are the one, or the other person is doing the compressions, and you need to do the intubation. So you make sure you have a laryngoscope available and an endotracheal tube available in order to do that, right? Once you have your endotracheal tube in place, make sure you inflate the cuff on the tube and you tie that in, because when you're doing chest compression, sometimes it's pretty aggressive. And in those cases, if your tube is not properly tied, it could easily dislodge and come out. So make sure you are paying attention to that. The typical guidelines that are suggested when we are ventilating for these animals include that you should breathe about 10 times in a minute for these guys. And your breath should be about 1 second long. And the tidal volume, the amount of air that you're putting in the lungs with each breath, should be about 10 mils per kilo. So if you have a 10 kilo animal, you're looking at about 100 mil of tidal volume. And very important that avoid hyperventilation. A CPR is a high stress situation. People are stressed out. They're trying to do the best they can. And a lot of the time they lose touch with those recommendations and guidelines. So it's very important to remind yourself that in that stressful situation, I do not put too much pressure in the chest of my animal, or I do not hyperventilate. Because if you are hyperventilating, that hypocapnia can cause cerebral vasoconstriction, which can decrease oxygen delivery to the brain. And if you are putting too much pressure in the chest, that can cause a drop in your preload, and that can decrease your cardiac output, obviously counter to what we are trying to achieve. So very important to pay attention to these guidelines. The scenario too could be that you are there by yourself. You cannot intubate because you have to do compressions as well. So in that case, it is suggested that you do what they call mouth to snout ventilation. So what you do is you close the mouth animal with one hand, extend their neck to align with the back of the animal, and then you seal with your mouth around the animal's nose, essentially. And then you exhale into the animal till you see a visible chest insufflation in those animals. So if you have an artificial manual breathing unit or an ambu bag, you can use a tight or close-fitting mask with that to deliver ventilation as well. You are the only person available doing the CPR, what the guidelines recommend is that you do 3 compressions and then 2 breaths followed by that, and then you go on to your 3 compressions. So this is how you complete your 2-minute cycle. Okay. All right. So after basic life support, which involve compressions and ventilation, now you move on to third key area, which is the advanced life support for these animals. So while somebody is doing the basic life support, somebody is hopefully ventilating for the animal, somebody is doing the compressions, you need to start thinking, your team need to start thinking, okay, I need to get other stuff ready. If I need any drugs, if I need any monitoring devices to monitor my patient, so they should all be working together as a team to get that stuff together. So in advanced life support, there are key 3 areas that are looked at. One is monitoring, what sort of monitoring we should use, what sort of drugs we should use, and for defibrillation, how we should defibrillate these animals if we indeed see an electrocardiogram that warrants defibrillation. And we'll talk about that in coming slides. So monitoring during CPR. Now, during cardiopulmonary arrest, you do not have any circulation available. So there is really no idea in using pulse oximetry or arterial blood pressure monitoring, because these devices in that stagnant circulatory conditions will not be helpful, will not yield any information. But on the other hand, electrocardiography and capnography is the most desired type of monitoring devices that we need or are recommended to be used for monitoring in these cardiopulmonary arrest situations. Remember that capnography gives us an idea about ventilation by measuring the end tidal CO2 from our patients during chest compressions. And this could be used during chest compressions. So even if you're doing chest compressions, you would still have a good looking capnographic waveform that you can use to evaluate how well you are compressed or doing your compressions. Rhythm analysis, again, is very important, as we talked about earlier, because it is depending on the rhythm of the animal that you will decide what sort of drug I need to use to address that scenario if the patient needs defibrillation. So capnography, CPR. As we talked about, capnography gives us end tidal carbon dioxide, and this value correlates with alveolar ventilation, and secondly, the cardiac output. So during CPR, remember we talked about ventilation, that there are set guidelines. If you are adhering to those guidelines, this means that your alveolar ventilation should be constant, because you are giving set number of breaths, set tidal volume, and your inspiration time is fixed. So this means that if you see any change in end tidal CO2, that would be a reflection of change in your cardiac output. So this becomes a way to evaluate the change in cardiac output, which is again very desirable, because that's exactly what you're trying to do, to reestablish blood flow, to reestablish the cardiac output. So if we look at this graph here, guys, so this is just an experimental data from pigs again that suggests that, so they induced ventricular fibrillation in these pigs, and you can see that full baseline blood flow in these animals shown by the bar graph, the tall bar graph, and the dotted line is showing the change in CO2, your end-tidal CO2. So as they induce ventricular fibrillation, the cardiac output goes to zero, and you can see that dotted line, it also drops to zero. So if there is no flow, there is no end-tidal CO2. And then in between, they start to do CPR. And during that CPR, depending on how well of compressions they are doing, they are generating some cardiac output. You can see those small bar graphs. And you also see that your dotted line goes up. So your end-tidal CO2 also goes up. Now, if you pay attention to at the end of that CPR, where it says defib, so the defibrillate, they use the defibrillator to defibrillate, and then the animal goes back into normal rhythm. And when that happens, you reestablish your cardiac output, and your end-tidal CO2, as you can see, goes back up very acutely, very quickly. So you shoot on your end-tidal CO2. So based on this data, you can suggest that end-tidal capnography or end-tidal measurement of CO2 is a great tool to evaluate the return of spontaneous circulation. So when you reestablish blood flow, you see that acute increase in your CO2 levels. And the data suggests that during CPR, if your patient's end-tidal CO2 stays below 10 to 15, they tend not to do very well. You know, they usually are dead at the end of that CPR. So if you can reestablish that better CO2, means better blood, better outcome. And then sudden acute increase means that you have reestablished that blood flow. Electrocardiography, as we talked about, is a key determinant. The rhythm determination is key in a sense that depending on the rhythm in your animal, you will decide, should this patient get this drug or should I do defibrillation? So very important part of that. And the lead should be placed while somebody's doing the compression. You don't tell somebody, oh, can you stop? I want to put the leads on my animal. So everything is happening at the same time while you're doing the compressions. Because remember, compressions are very important. You do not stop doing compressions. Once you have monitoring devices in place, you have electrocardiogram in place, then you start looking at the rhythm and you start thinking about the drugs and the routes. So what drug administration routes are available to us? So after you have the monitoring devices in place, then your next priority is that, okay, let's get an IV catheter in this animal if I do not already have an IV access. And it's desirable that, if you can place the catheter in a vessel that is closer to the heart, because remember that you're trying to do compression, that's what moves the blood. That is what will move the drug to the point of the interest, which is your heart, right? So if your catheter is further away from the heart, it might take longer. So that means that a cephalic vein might be more desirable than saphenous vein catheter, right? From that standpoint. If you can put a more central catheter, like in a jugular vein, that's even more desirable. If you can't access the catheter normally, consider cut down. Make sure you have some sort of surgical blade or instruments available that you can do a quick cut down of the vessel and then place the catheter in those animals. In very small size animals, puppies and kittens, intravenous access could be really challenging. So in those cases, you can consider putting an intraosseous catheter. And I've shown that, trochanteric fossa in the femur might be a desirable place for that. Reason being that you're in the back end of the animal. So if somebody is doing the compression in the front end, they can keep doing their compressions and you can still work on your intraosseous catheter placement without disturbing them. And if you can't get either your intravenous or intraosseous catheter, then it is suggested that you can actually give drugs intratracheal. So if you have intubated your animal, you can just use the endotracheal tube to deliver the drugs into the lungs where it gets absorbed. So that's a different way of delivering the drugs. If any of your patient was sedated for whatever reason, let's say you're doing an MRI, CT scan, or a radiograph that you sedated an animal for that, and then they arrest, it is very important that you consider reversing that drug that you have used, right? So if you look at this table, if you have used an opioid, maybe butorphanol, morphine, hydromorphone, fentanyl, whatever the opioid you may have used, you can reverse the effect of that drug with naloxone in this case. If you have used a benzodiazepine like diazepam or midazolam, for example, then you can use flumazenil. If you have used an alpha-2 agonist like xylazine or dexmedetomidine or imifidine or detomidine, any of those drugs, you can use atipamezole. If you do not have atipamezole, you can use yohimbine or telazidine. So there are different options for alpha-2 antagonists that can be used. The most common rhythms that you notice when the patient is under arrest are 4 typical rhythms that you can notice. So the first one is asystole, that there is a flat line. You can't see any sort of rhythm. The second one is pulseless electrical activity. This means that you are still seeing some complexes on your electrocardiogram, but there is no associated pulse or mechanical activity of the heart with those pulses or with those electrical activities. Then the third could be the ventricular fibrillation or VFib. Remember, is essentially an uncoordinated contraction of different myocardial cells, right? So there is no coordination. You're simply seeing fibrillation. You're simply seeing small little undulations in your baseline. Or your patient could have what they call pulseless ventricular tachycardia, which means that the rate of your ventricular firing is so high that there is not enough time for the ventricle to fill. When that's the case, your preload is minimal and your cardiac output would be 0, right? So these are the 4 rhythms which are essentially key to understanding what sort of a therapy would be needed moving forward in that animal. So understanding if a rhythm is a shockable rhythm, that it should be shocked, the animal should be shocked with a defibrillator or not, a simple algorithm could be used for that. So you simply look at your ECG. You look at, are there consistent repeating complexes available on that ECG? And if the answer is no, then you look at ECG. Is it a flat line? If the ECG is a flat line, it could mean that this is asystole, right? There is nothing going on with the heart. The heart is stopped. So that's asystole. And asystole is a non-shockable rhythm. You do not need to defibrillate these animals. Or you see that it is a flat line, but it is indeed, there are some fluctuations or there are some undulations in the baseline that you're noticing, which could be fine ventricular fibrillation. And if you have VFib, then it is a shockable rhythm. You know that I need to use the defibrillator in order to correct that rhythm. So if initially when you look at your ECG, there are consistent repeating complexes, if the answer is yes, then you look at that, are there any pulses? Can you feel a pulse with those complexes? If you are indeed feeling a pulse, that means that, okay, you have reestablished circulation. So there is a perfusion available to that animal. So that's good, you got the patient back. But if the answer is no, then you need to look at the rate. If the rate on the ECG is more than 200 per minute, it essentially means that this is a pulseless ventricular tachycardia, that your ventricular rate is so high that there is no cardiac output associated with that. And this is a shockable rhythm. So this patient should be categorized that it should get a defibrillation. Or if you're seeing complexes and the heart rate is below 200 and there are no pulses, then you're left with that, okay, this is pulseless electrical activity. I'm seeing some activity on the electrocardiogram, but there is no mechanical activity associated with this electrical activity. So that is a non-shockable rhythm. So that's how electrocardiogram help us differentiate that what sort of rhythm is there and how I should move forward in order to address that. So let's start with the non-shockable rhythms, which are your asystole and pulseless electrical activity, as we just talked about. And the one major category of drugs used to address this rhythm is your vasopressors. And the 2 main vasopressors used during CPR is epinephrine and vasopressin. And the objective of using a vasopressor is to vasoconstrict your peripheral circulation so that you move all the blood into the central circulation where your vital organs are, your heart, your brain, your kidneys. So those are the ones that needs that perfusion. So you cause vasoconstriction in the peripheral circulation and the blood moves back into the central circulation. So let's start with epinephrine, a very important player in our life support, in our advanced life support. So it is recommended that when you're using epinephrine that you start with a low dose. For a very long, when I was a resident and when I was back home in India, our typical way of giving epinephrine was high dose epinephrine, which was 0.1 milligram per kilo dose. But if you look at the experimental data and the data from human side, it suggests that if you start off with a low dose of epinephrine, as is shown in the table here, a dose of 10 times less than 0.1, which is 0.01, then there is there tends to be a better survival to discharge in people, at least. The data suggests that if you start off with a low dose. And this dose should be given every other cycle. So you do your first 2-minute cycle, you can give the dose, and then you wait for the other cycle, and then you go to the other cycle after that, and then give the other dose. So every other cycle, you could repeat the dose. Now, you could consider going to the high dose in cases where you are doing a CPR for a long time and you have not gotten your patient back. So let's say if you are beyond 10 minutes, you've been doing all this, the patient still has not responded. In that case, they say that, okay, now you can probably go on to a high dose. Again, if you do not have an IV or intraosseous access available, you can give epinephrine via the intratracheal route, right? If you have intubated your animal, you can just give that drug through the endotracheal tube. Remember that the suggestion here is that when you're doing intratracheal administration, your dose of epinephrine should be about 2 to 10 times higher than what you would give with IV dosing, right? And it's suggested that to increase the amount of volume, you dilute your epinephrine dose with saline or with sterile water in 1:1 ratio. So if your dose is 1 ml, you add a ml of saline or sterile water to make it 2 ml, and then you infuse that through your endotracheal tube into your animal. The second vasopressor that is typically used during CPRs or could be used during CPR is vasopressin. Now, vasopressin has a different mechanism of action compared to epinephrine because this is not an adrenergic action. It acts via a very different receptor type called V1A receptor in the vasculature. And some of the potential theoretical benefits of vasopressin over epinephrine is that it maintains its efficacy as a vasopressor in acidic conditions. Now, remember that if you do not have a circulation, if your patient has arrested, you go into anaerobic metabolism because there is no oxygen delivery. And when that happens, you start to build lactic acid. So hyperlactatemia and lactic metabolic acidosis is typically a scenario that we come across in these arrest situations. So your pH goes down. And it's been shown that drugs like epinephrine do not work very well in that acidic environment. So using a drug like vasopressin in that scenario might be a reasonable choice. Also, it lacks any beta-1 effects. Remember that beta-1 receptors are present in the myocardium, and they play a key role in managing contractility and heart rate. And increase in contractility and heart rate although seems desirable in these situations, but you can imagine if you are not perfusing that myocardium, and at the same time you ask that myocardium to perform more aggressively, their oxygen demand would go up. So that means more potential of arrhythmias could happen in those animals, right? If you have a drug that has a beta-1 effect. So this drug lacks that effect, so that could be a theoretical benefit with using vasopressin. These are theoretical benefits, but if you look at in depth the literature review from human data as well as some data from veterinary side, it's been shown that there is no survival benefit of using vasopressin. That if you're using vasopressin over epinephrine, it does not really improve your outcome. So based on this data, it suggested that it's fine if you want to use vasopressin by itself and not use epinephrine, or you can use both of these drugs in combination. So you could give 1 dose of epinephrine during 1 cycle, and then for the other cycle, you could give your vasopressin in those cases. Further, the next class of drugs is your vagolytic or anticholinergic drugs. So that drug is atropine. In the past, we had always used atropine during CPRs. But if you look at the recent data, so that was the whole idea of these CPR recover guidelines, to look at the evidence for or against what we are doing. So the data or the evidence from that whole analysis comes out that it doesn't really matter if you're using atropine or not. It doesn't really have much bearing on the outcome, but it doesn't really cause anything bad to the animals. So they suggested that, if you have a non-shockable rhythm, it is fine if you want to use atropine. It's fine if you do not want to use atropine. But the most important thing is that if you have, as a clinician, if you know that your patient arrested because the patient had a high vagal tone, or a high parasympathetic tone from whatever reason, whatever the pre-existing disease may be, or the drug you may have used, then it is reasonable to give them a vagolytic agent like atropine. And also, if you do not have IV or intraosseous route available, then you can give this drug as intratracheal. And the pharmacokinetic of atropine is such that one dose should be enough for intratracheal administration for atropine. Now, after we have talked about the non-shockable rhythms, your asystole and your pulseless electrical activity, now let's move on to if you have a shockable rhythm, the rhythm that you think should be treated with electrical defibrillation. In these cases, you are either dealing with ventricular fibrillation or pulseless ventricular tachycardia. So electrical defibrillation would be an ideal choice in these animals. So obviously, you have a dose rate, the energy recommendations available, that how many joules per kilo of energy you should deliver in order to cause defibrillation. And it depends that if you're doing an external defibrillation, as the picture shows, that you could have an external patch, that you can use for external defibrillation, which is the most common that is defibrillation that we do. Or if you have a patient that is in surgery and you're doing a thoracotomy, you have the chest open, or you have the abdomen open, you can just incise the diaphragm and get into the chest and around the heart. So you can get those internal paddles directly over the heart. So as long as you have the chest open, so this is what we call an open CPR, open chest CPR. So if you are in a scenario where chest is open, you can use that. Or if the owner has given you consent that they can that we can do an open chest CPR, then you quickly just do a lateral thoracotomy and go into the chest, and then use the internal pad if you have to, or do the compressions directly on the heart. In humans, the data suggests that if you are able to do early defibrillation, it improves your chances of survival tremendously. So if you do see a rhythm that is amenable to defibrillation, do not lose any time. Get your defibrillator while you're doing compressions and defibrillate the animal right away. Again, once you defibrillate your animal, do not wait to see what happened. Go back to your compressions right away, because your defibrillation might have turned your animal into a normal rhythm, or it may not have. So if it turns into a normal rhythm, great, you are already doing compressions, you're helping the animal. But if it did not, then you are obviously helping the animal because there is no rhythm underneath. And then once you've done your 2-minute cycle, then you look at that back from that shock that, okay, do I have a rhythm or not at that time? It's recommended that you use biphasic defibrillator, which essentially means that the current is coming from both of the pads. And when that is the case, in that case, you can use less current to deliver your defibrillation, which is nicer for the heart because you are not frying the myocardium by giving too much current in those cases. If a defibrillator is not available, very important, because this is something that is not available with every practice. What they're suggesting is that you can use the precordial thumb, and you might remember that this is essentially giving a firm blow right over the heart of the animal in a hope that this will mechanically cause the defibrillation of that heart. Now, this is okay if you do not have a defibrillator available, but if you just decide to do that in every patient, the efficacy is very low. You can't guarantee that the precordial thumb will translate into an actual good rhythm. And then in the drug class, we have the anti. Let's say if your patient does not respond to electrical defibrillation, then it is suggested that you go on to amiodarone. If you do not have amiodarone, again, amiodarone is also a somewhat specialized antiarrhythmic, and not every practice carries that. So if you do not have that, the data suggests that you can use actually lidocaine, and lidocaine probably is a more widespread drug that is available in a lot of the clinics. So that could be used. Fluid therapy. In the past, people used to start pouring a lot of fluids in these CPR animals. Okay, just open the bag and give them fluids in a hope that you're improving perfusion. And that is fine as long as your patient actually needs fluids. If they're hypovolemic, sure, give them fluids. But if they're not hypovolemic, what are you doing? When you give them fluids, you increase your right atrial pressure. when the pressure in the right atrium goes up, you decrease the perfusion to your myocardium. Remember that myocardial perfusion is determined by the difference between your diastolic pressure and your right aortic pressure, right atrial pressure. So if the right atrial pressure goes up, your perfusion overall would go down because you decrease coronary perfusion pressure. So make sure you are giving fluid to the patients that actually needs fluids and not as a therapy. Sodium bicarbonate or your alkalinizing therapy, should you or should you not use it? Now, it is easy to imagine, as we talked about earlier, is that if your patient is arrested, they go into anaerobic metabolism. So they start producing lactate. So there is a lot of lactate floating around in your animal. So the pH goes down. So if you are in a prolonged CPR situation and you have looked at a blood gas that shows you that, okay, the pH is really low. In this case, they typically say if the pH goes below 7, then definitely you can consider giving these animals bicarb in order to hopefully improve the pH in these animals. Because remember that acidic environment is not the greatest thing because it inhibits your enzymatic and metabolic activity, it decreases cardiac contractility, and it causes vasodilation. So all the things that will impair our return to the outcome that we're trying to achieve in these cases. So addressing that becomes important as well. Now, the final part in that equation is post-cardiac arrest period, that, okay, you've got your patient back. Okay, what do I need to do now to keep them going, to keep them alive? Look at the data, it suggests that in humans, about 60 to 70% of humans, they come back. They achieve return of spontaneous circulation, But if you look at the veterinary data, 35 to 45% achieve return of spontaneous circulation, but out of that, only 2 to 10% gets out of the hospital. So obviously, this gives us this huge opportunity that, okay, what is happening in this period of time? I got the patient back, but why the hell they did not stay alive? What happened wrong? What went wrong, right? So this is where the post-cardiac arrest period comes into play, that what we can do to improve their outcome. So why they think this happens during this period is that they're calling this a PCA syndrome or post-cardiac arrest syndrome, which is characterized by your multiple organ dysfunction syndrome, cardiogenic shock, anoxic brain injury, and any of the pre-existing diseases that might already be there in the animal. It's a combination of those things, which is called the PCA syndrome, and that leads to demise of these animals, even though you got them back earlier. So this is an important area where if you optimize the care of these animals, you can improve their outcome. So post-cardiac arrest, so if you are working in such a critical anesthetic or emergent scenario, then you gotta make sure that you're ready to support these animals once you've got them back. Okay, so that's exactly what we're going to talk about in these recommendations. So there are three key recommendations in this area. So the first one is hemodynamic optimization. What strategies or what should I do? Where should I maintain my blood pressures? How should I ventilate? Where should the respiratory function be in these animals? And finally, how can I maintain the brain function in those animals? Because remember, it's a huge thing in humans. If a human arrests, you got them back. But when they wake up, they can't speak. They can't move their limbs. It's a huge impact on that patient and their family. Same thing with the animals, if the animal wakes up blind, or can't use its legs or whatnot, it's a huge stress on the owners. So that's why very important to pay attention to these things. So quickly, I know we are running out of time, so it shouldn't take very long, guys, so please bear with me. So the first one is the hemodynamic optimization. So they suggest that you should do an individualized goal-directed endpoints, which means that every patient is different. If a blood pressure A is better in patient X, it might not be the same thing when a patient B is there, so you might need a different endpoint in that animal. So that's why they say that you should set individual goals in every patient. And those goals could be set either by central venous oxygen saturation. You can look at their lactate levels. You can set the pressure outcome in those animals. You can look at your central venous pressure. You can look at arterial oxygen saturation if you have an arterial catheter in those animals. Or you could look at the PCVs in those animals. If you had a trauma patient that had bled out profusely, you can look at the PCV as an endpoint as well in those animals in the resuscitation period. For the blood pressure, it is recommended that at least normal or at least slightly above normal pressure in these animals, because it's been shown that the autoregulation of different organs, including your brain, is impaired in this period. They cannot maintain perfusion to their brain very well, and it directly is impacted by the pressure in those animals. So if the pressure goes down, the perfusion goes down. So it's very important that you maintain slightly higher pressure than normal in these animals so that you can keep perfusing your brain and other organs. And the typical recommendation based on one of the studies from General Stroke is that you should maintain a mean arterial pressure of more than or equal to 80 millimeters of mercury. Remember that in small animal patients, we typically say that 60 is an okay number because that's a lower limit of autoregulation of different organ systems. But in this case, you go beyond that. You say that at least you need 80 or more than that in order to maintain that perfusion. Fluid therapy, again, you can use fluids to improve pressures, again, with the caveat we talked about earlier, that if a patient is euvolemic, is hydrated properly, do not overload them with the fluids. And finally, you can use vasopressors like dopamine or norepinephrine in order to cause vasoconstriction if you have a patient that is profoundly vasodilated. Let's say you had a patient that is septic who arrested, right? So we know that vasodilation is part of their pathophysiology, so you can use a vasoconstrictor in those animals, a vasopressor. Or if you have an evidence that there is drop in myocardial contractility, remember we talked about cardiogenic shock in these animals in the post-arrest period. So you can help improve their contractility. So you can use drugs like dobutamine. Dopamine can also help with that, right? So that's your option to improve pressures. The next one is respiratory optimization. How do we make sure we are ventilating for them okay? Now, it is important to maintain these patients on a ventilator for some time if they are not breathing on their own in order to ensure that you maintain normal CO2. Because remember, we talked about earlier that if the patient is hypercapnic, that can cause cerebral vasoconstriction. So blood flow to your brain could go down, right? So important to maintain normal CO2s in these animals. Also, when it comes to oxygenation, it is important that you maintain normoxemia, which is normal level of oxygen and not too high of a level of oxygen. I mean, in theory, it seems that, okay, if you have a very high level of oxygen in the blood, it might be nicer. But in this case, a very high level of oxygen means more ability or more potential for oxygen particles to be formed. And when that happens, that can lead to further organ injury. So they suggest that you should probably only maintain normoxia and not hyperoxia in these animals. Obviously, animals could be comatose, so you need to breathe for them. You know, you got the heart back, but they're still not breathing very well on their own, so they need ventilation in those cases. And finally, the neuroprotection. What can we do to maintain or prevent any neuronal injury in these animals? So it's been suggested that the core body temperature of these animals should be maintained below normal. So these animals should be kept actually hypothermic. Remember that hypothermia decreases the need for oxygen delivery or demand in the brain. So if that is the case, you can prevent the activity or you can prevent the heart and brain from experiencing any injury much better than if they are at normal thermic temperature. So it is recommended that you maintain these patients anywhere between 33 and 36 degrees centigrade or 91.4 to 96.8 degrees Fahrenheit. When you decide to rewarm these animals, okay, your now patient is doing great, okay, now I need to start rewarming these animals, then the rate of rewarming should not go above 1 degree centigrade per hour. And what they're suggesting is that your rate should be anywhere between 0.25 to 0.5 degrees centigrade every hour when you are rewarming these patients. A lot of these patients can seizure in that period. So, and remember that when a brain or a patient is seizing, it increases their oxygen demand tremendously, right? And an animal that is already struggling with a poor, probably brain function, having seizures on top of that is only going to worsen the outcome. So it's very important that if an animal is seizing, that you aggressively treat those animals with drugs like benzodiazepines. You know, you have diazepam, you have midazolam, you know, any of those options would be reasonable for treating seizures. And finally, if a patient is persistently comatose and is apneic, you know, then it is recommended that you can try some mannitol or hypertonic saline in those animals in a hope that it will remove any extra interstitial fluid volume in the brain that might be there when the injury to the brain tissue actually happened. So having a hyperosmotic agent therapy in those situations might be beneficial. I think that's pretty much what I have, guys. All right, so I know that I did see there were some questions coming in, and I apologize that WebEx format is something that we don't use very commonly here. We typically use Zoom format here, so I'm not very familiar with this setup. But I could try to answer these questions later, via email. What do you think, Dr. Nilesh?
Yes, sir, we can ask one or two questions.
Sorry?
We can discuss one or two questions, sir.
Yeah, yes, please. If somebody has questions, I would be happy to.
Questions to you, sir.
That sounds good.
Yeah,
yes.
Please. Yeah.
Yes, sir. Sir, thank you once again for such a wonderful talk. And this is really informative for all. And there are many participants also who are being associated with us on Facebook channel of ISVM, and they are seeing you live. And one question is from Dr. Fuse. What drug you suggest if BP drops by any regions during anesthesia or while doing surgery?
Okay. So the simple answer to that is that when you talk about blood pressure, remember blood pressure is dependent on two variables. One is your cardiac output, and the other is your resistance or the tone in your vessels. So this means that depending on your patient, one variable might be overpowering the other variable. But if you want a general assessment or a comment about addressing hypotension, if the patient is under anesthesia, the first thing you need to do is turn off the anesthesia. Any drugs that you're giving, you should reverse those drugs. You should turn off the vaporizer so that you're not delivering any isoflurane, sevoflurane, or whatever the case may be. And then you look at their heart rates, because remember that heart rate is part of that blood pressure equation. Cardiac output is product of heart rate and stroke volume. So if your heart rate is low, I'll treat that. If the patient is hypovolemic, I will give them volume. I will give them crystalloids. You can use normal saline. You can use Normosul. You can use Plasma-Lyte. Any of those fluids should be fine. If the patient has low oncotic pressure, you can use colloids in those animals. If the patient has lost blood, let's say it's a trauma animal, you can give them blood, right? So it depends on what type of patient you're dealing with. When it comes to other sympathomimetic or tricholamines, you can use either dopamine or dobutamine. So I think those are the typical drugs that we start off with. If they don't help, then we start thinking about drugs like epinephrine, norepinephrine, vasopressin. So those are kind of, the extreme step that we take that, okay, these standard strategies are not helping now. So let's think about those more aggressive drugs at that time.
Thank you, sir. One more question is here. What is the success rate of CPR in dogs and cats? By Dr. Gunjan.
Yeah. So as we talked about a little bit in the presentation, that if you only talk about a return of spontaneous circulation, that you get their heart rate back or their heartbeat back, that's about 40 to 50% in case of dogs and cats, compared to 60 to 70% in case of human beings. So, that's not bad. But again, remember that return of spontaneous circulation is an intermediate outcome. That is not the eventual outcome. Your outcome that you're looking for is that how many patients get out of your hospital alive. That is exactly why we talked about the post-cardiac arrest period. Okay, you got back. Now you have this post-cardiac period that you have to support these animals. So that's where the problem comes, that a lot of these animals die in that period. And as we talked a little bit in the presentation, it's only about 2 to 10% of these animals that actually make it out of the hospital alive. So not a huge rate, unfortunately. That is why I asserted right in the beginning that knowing that this is already a killer, that when your patient arrests, you need to do anything and everything to make sure that you are adhering to those set evidence-based guidelines so that you can do the best job possible for your animals.
Yeah, thank you, sir.
Thank you very much.
One more last question from my
Of
side.
course.
Dr. Pius again asks, in case of hemorrhagic gastroenteritis, most common cause of death is circulatory collapse. So can you suggest any CPR drug for maintaining BP apart from plasma volume extender and fluid therapy?
Yeah. So, out already that the most important thing in those animals is maintaining the blood volume. So you said, okay, you already have. So beyond that, you could look at these animals as needing vasopressors or inotropes. So the most common drugs that we typically start off with is either using doburamine or dopamine. So one of those drugs probably would be a reasonable choice to start off in those animals. Probably dopamine. If you're going after pressure, I'll probably start first with dopamine. And if that does not help, then I can try doburamine or try those drugs in combination.
Thank you, sir. Thanks for such a nice and informative webinar. And
thank you, guys. Thank you, everybody.
Next step is a vote of thanks by Dr. Sawan Singh. I welcome Dr. Sawan Singh again, and I request Dr. Sawan Singh to provide a vote of thanks for the esteemed speaker, please.
Thank you, Dr. Nilesh. That's a very wonderful talk by Dr. Amandeep. First of all, I thanks our luminous, or you can say our buddy, our friend, our beta, Dr. Amandeep Chohan, to give a very good talk this evening and probably the morning there. And secondly, I want to say thanks to all the participants who have, you can say, wholeheartedly participated in this talk. And I want that their queries should be met, and I want them to please give a mail to Dr. Amandeep Chohan so that he can give answer to your queries.
Yes, no, I think, thank you, Dr. Randhawa. I think that's a great idea. I know that this is a topic where many people have questions. So if I can help answer any of those questions, I would be more than happy. And Dr. Randhawa or Dr. Nilesh can share my email ID with you guys, and you're welcome to share your comments, your suggestions, or your questions, and I'll be happy to answer any of those questions.
You can say.
Thanks. Dr. Randhawa, or Dr. Nilesh, I would really love to have some feedback, how things went, is there something more that the people were looking for, what went well, maybe, what was something that was not that great, so that, in future, if we do come together, that, I can hopefully improve on some of those deficiencies if folks think that I need to do something different.
Dr. Ahmed, I think that we have to address the first question you have asked, that you have to have a very didactic training.
Yes, absolutely. That is the first. I think, once you understand the theory behind what we are doing, then you go into practice. Okay, then you start doing simulations, and it's really easy. I mean, you can pretty much find a toy big dog, and just practice on that. Okay, if your resident or students are training on that, you can simulate. Okay, they're doing compressions. Somebody could be sitting behind a monitor and change the heart rate on that, and just giving them feedback. Okay, what you're doing is doing this. Okay, now what do you do next, right? So starting thinking about that, okay, and now that you understand the theory, how can I train my people in order to actually do this stuff? So that's where simulation comes into play. And again, and also real scenarios, if you do have a patient arrested and you did a CPR, doesn't matter if this was successful or unsuccessful, you come back together as a team again to talk about it. Okay, because we didn't talk about these things in details because that's a very huge topic. You need to have a team dynamics. You should have a team leader that is telling your team, okay, you do this, you do this, you do that, right? And then you all get together at the end and talk about, okay, what went well, what could I have done better? So that's what makes it better. Nobody's perfect. We all learn from our mistakes, and CPR area, which gives us this huge opportunity that when we do this stuff, we get together again for debrief and learn from what happened. Dr. Nilesh, is there any other question that I would be happy to answer if there is anything else? Otherwise, like I said, I'm open to any other questions or comments, that folks want to send me via my email later, that
Dr. Aman, Dr. Aman, can you hear me?
Yes.
So just, I think there are a lot many questions right from the start and to the end. So we can email you our queries. And I think we are all thankful to you to give a very good, wonderful talk. And along with the participants, organizers, because this can't be possible because of course, this is a webinar going on, but I think this is a good platform in COVID, you can say pandemic, that we are getting together and we are discussing something or one thing or other on this, you can say, platform. So thank you very much for giving a very wonderful talk. Thank you very much.
Thank you so much, Dr. Randhawa, Dr. Nilesh, Dr. Galdhar, and everybody in the ISVM organization team for helping me deliver this talk. And again, when the question comes back to me, I will make sure that I get back to you guys with the answers to those questions. And hopefully we'll get more opportunities to get together in future to talk about some other topics. Again, Thank you so much, everyone. Thank you so much.
Thank you.
Thank you so much, sir. And thank you to all of you. Namaskar.
Really wonderful talk, and our all audience enjoyed the things very nicely, sir.
Thank you. Thank you, guys. Thank you, everyone. Thank you.
Thank you.